Middle East or Asia.
Thing is, so this one actually we can.
And needles coming from distal.
Tendon moves together.
The tendons that is being stabilized by this pulley system. Good morning, good evening, and good afternoon, wherever you are in this part of the world. And first of all, I would like to congratulate the organizers of IART for organizing this online hybrid conference on perineural injection using 5% dextrose. Dr. Lisa Jeimylo invited me to discuss about the ultrasound-guided lower extremity nerve hydrodissection. And I'm happy to share with you this today, the different approaches that we can use to identify the nerves and at the same time to do the appropriate nerve injections to those areas which are causes of pain in our patients. So first of all, I would like to inform everyone about how thankful I am for being part of this. And I hope this information will help you in your practice in the future. So I have no disclosure, but I have as a beautiful inspirational text found in Isaiah 48, 29-31. It says here, God gives power to the weak, and to those who have no might, he increases strength. Even the youth shall faint and be weary, and the young men shall utterly fall. But those who wait upon the Lord shall renew their strength. They shall mount up with wings as eagles. They shall run and not faint. Now, this is an inspirational text for me because of the fact that not all the problems medically in the musculoskeletal areas are within our reach. And sometimes, even if we know a part of what we already know at the moment, sometimes we experience challenges. It's always important to rely on the providence of the goodness of the Lord for all these things that we are able to treat our patients. So let me just identify the nerves that we are going to do this today. And I divided into nerves on the hip region, the knee region, and of course the ankle region. And as you can see here, there are different nerves, a lot of them in the lower extremity. And I would like to highlight those very important nerves that we might encounter in our approach in treating our patients. I would not want to identify all those because you can see it already in this presentation. So first of all, I would like to mention that all the nerves in the lower extremity arises from the lumbosacral plexus, I would say. So these nerves actually is divided into two parts. We have, I would say, the more proximal, which is coming from your T12, L1, L2, L3, and L4. And then we have the more distal, which is arising from L4, L5, S1, S2, and S3. And as you can see from these nerves, we have a lot of different peripheral nerves arising either from the roots itself or from the trunk. And then, of course, from a combination of different peripheral nerves, like your sciatic nerve here, or it could also arise as distal branches of those peripheral nerves. So each nerve is unique in the sense that they may come from sources or origin which may not be the way we think in terms of, let's say, comparing it to the brachial plexus, which is really separated into the roots. And of course, we have the trunk, the cord, and then we have the different branches, peripheral branches of the nerves. And so the lumbosacral plexus doesn't follow exactly the way the brachial plexus is organized. Okay, so here let me begin by identifying these different nerves at the inguinal area. So these are your ilioinguinal, iliohypogastric, and genitofemoral nerves. And these are actually nerves which proximally arises from T12 up to about L2. So as you can see here, we have your iliohypogastric, which is coming from your T12 and L1, we have your ilioinguinal nerve, which is purely coming from L1, and we have your genitofemoral nerve, which is a combination of your L1 and your L2. And just to mention here that these genitofemoral nerves are the ones which innervates the scrotal area and the labia majora for females. And of course, this also innervates the lumboinguinal nerves. So this is very tiny, these are very tiny nerves, and sometimes it's a challenge to identify exactly the location. But my concentration in this lecture is from the ultrasound level. Somebody else will talk about how to identify these nerves from the surface based on the landmarks. But right here, we will just be focusing on the ultrasound images and how to reference them based on the ultrasound itself. So as you can see here, the inguinal nerve and the iliohypogastric nerve, and of course the genitofemoral nerves, would usually commonly is located right at the mid portion of the inguinal ligament. So if you're looking at the inguinal area, then you can see the distribution of these different nerves. There is a nerve that goes into your scrotal area. Okay, so these are nerves which may be unique. And then of course we have a nerve that could go all the way to the proximal part of the scrotum. And then of course there is the branch that goes just at the mid-thigh region and the proximal area of the inguinal area. So if you will look at these different nerves, let's say your iliohypogastric, this is a mixed nerve. It is a sensory and motor, and some of its fibers will also innervate the transversus abdominis, rectus abdominis, pyramidal muscles, and abdominal oblique muscles. Same holds true with your ilioinguinal and of course your genitofemoral nerve. And of course, as we go along this lecture, we will also see lateral femoral cutaneous nerve, which is very close to these nerves. So all of these nerves that we have initially identified are mixed nerves. So they are both sensory and motor. So if you're looking at the ultrasound, for instance, and you put the probe referencing it from the anterior superior iliac spine right here, you can already see actually 3 layers. Now, depending on the orientation of your ultrasound, for instance, if you go it more distal, you can only see 2 layers. These are your internal oblique and transversus abdominis. So for you to see all those 3 layers, what you have to do is to move it more proximally going up with one part of the probe facing the anterior superior iliac spine and the other segment of the probe facing your umbilicus. So with that being positioned on an oblique manner, then you would be able to see all these layers. So as I've mentioned, if you move it distally, you can only see 2 layers. So you might think there are only 2 layers of muscle, but actually if you move it a little upward, then you can see the 3 layers appearing here, which are your external oblique, your internal oblique, and your transversus abdominis. And the nerves that we're looking at is found at the fascia between your internal oblique and your transversus abdominis. So if you put your probe here, the more proximal in the sense that it's closer to your anterior superior iliac spine is your ilioinguinal, and of course the more medial is your iliohypogastric nerve. So this follows one fascia. So if you're going to inject it under ultrasound guidance, you'll be able to do it at the level of the fascia between your internal oblique and your transversus abdominis. Now, sometimes the question of will you be able to see these nerves? Of course, depending on the type of ultrasound that you're using. If you're using high frequency ultrasound, you'll be able to see it. But if you're using a very simple ultrasound, you might not see it. But just the same, if you're going to inject that area, you can still just hydrodissect the fascia, and then you're all the way to approaching your 2 nerves, which are located in this area. So the same holds true if you do your MRI. You can also see those nerves. And you can also identify those tiny nerves that has the same location as we have seen the ultrasound. Although the ultrasound is more dynamic, and you can just keep moving it in order to identify the area. Now, this is an example of a patient that is complaining of pain whose distribution is at the ilioinguinal iliohypogastric area. So what I did was to do an ultrasound-guided injection. I went all the way from your external oblique to internal oblique, and then of course your transverse abdominis, and then I kind of hydrodissect the fascia and try to see if there is the fluid has reached that area by which this nerve. So from here, I'll go all the way. You can see here the 3 layers: external oblique, internal oblique, and then transverse. And then I just go to the fascia between your internal oblique and transverse abdominis, and hoping that all these fluids will go all the way to the fascia where the nerves are located. And then, of course, we move to your genitofemoral nerve. So genitofemoral nerve originates from the ventral rami of S1 and S2. And depending on the orientation, it usually innervates the cremasteric muscle and skin of scrotum and labia majora. And it also has a femoral part, which supplies the anterior thigh and crosses the deep circumflex artery and deep to the inguinal ligament, and also lateral femoral artery. So usually the way to identify this is to go and look for your femoral nerve first. And you can see this nerve just beside your femoral nerve. It's a small nerve, and that's the exact location of the genitofemoral nerve. So here in this study, what you can see is about 21% is usually located medial to the femoral nerve, but in about 17% it is located lateral to the femoral nerve, which is actually what we rarely see. So in order to approach this nerve, you have to first locate for your femoral nerve, and then you can see it just beside your femoral nerve. So again, this is the other branches of this genitofemoral nerve. So it has several branches depending on the variability of the individual. So it has the medial, and of course it has a lateral branch. We'll not go into the detail of that nerve right here, but I just would like you to see here that there is a medial branch, there is a lateral branch, and then of course the medial branch is the genital branches right here, and of course the lateral branch goes all the way to the lateral part of the thigh. And of course the broken line here represents your inguinal ligament. And then of course that's the genitofemoral nerve. So if this is your femoral artery, this is your femoral nerve. So you can see the genitofemoral nerve as a small nerve just beside actually your femoral nerve. So let's move on to the hip region, and we're looking at the femoral nerve here. So the femoral nerve represents the posterior divisions of the ventral rami of L2, L3, and L4. Occasionally, there could be some prefix or postfix distribution, which means it could be L1 or postfix, which is L5. So it is situated in a very tight fascia between the psoas and iliacus muscle, and there is a critical zone of entrapment at the inguinal ligament, deeply by the iliopsoas and medially by iliopectineal band. So you don't quite see this area because it's very proximal. So if this is your femoral nerve right here, then the entrapment would happen actually inside prior to the inguinal ligament. And usually the compression is due to the hematoma that is present in this area. So if there is any trauma and there's a hematoma in this area, usually that nerve could be compressed and causing some degree of numbness and of course weakness if there's a severe type of impingement. So this is your femoral vein, this is your femoral nerve, femoral artery, and this is your femoral nerve. So that's kind of the location of this when you look at it from the ultrasound level. And then of course, we do a head resection. So as you can see here, this is the femoral artery, this is the femoral vein, and this is the nerve. So the needle is right here. And then of course we did a high dissection of the femoral nerve. The femoral nerve needle is right here. It goes all the way to the nerve, which is located here. And then I kind of high dissect the lower portion. And then I move towards the more superior part of the nerve to just complete the high dissection around the area using 5% dextrose. Okay. Then of course, it could also vary. I mean, the location of this femoral nerve, as you can see here, could be so small in relation to the artery and the vein. So try to be mindful about the appearance. If you say a honeycomb pattern here, then you're quite sure that you're dealing with the femoral nerve. So there are variety. It could be a high femoral nerve, or it could be a low femoral nerve, depending on the location. So it could be high up into the inguinal ligament or below that area. So this is just a slide that differentiates between the variety that you can see also in the femoral nerve in the process. So again, this is one nerve that here also innervates the anterior hip capsule. So if you have a patient which has pain on the hip, this could be one nerve that you need to consider to hydrosect in order to get rid of the pain anteriorly of the hip capsule. So there are two other nerves which can do that. And of course, we have your high obturator nerve. And of course, the other one is your superior gluteal nerve and occasionally the sciatic nerve. So this is also another slide of the anterior hip capsule with the innervation of the femoral nerve. So in other words, if we're dealing with the hip itself, so majority of the innervation of the anterior hip capsule comes from the femoral nerve. So there are two branches, which is from the muscular branch of the pectineus and of course, muscular branch of the iliopsoas. And this usually innervate the anteromedial and anterolateral part of the hip joint capsule. So any hip joint, usually this comes as an anterior hip impingement, or it could be the pincer type, or it could be the cum type, depending on what type of impingement. It could be a combination of hip impingement types. And then if that's painful and then you would like to get rid of that pain in the anterior hip, then the femoral nerve would be a good nerve to inject. Now in 85% also, the anterior obturator nerve and the posterior obturator nerve also innervate the inferior anteromedial aspect of the hip. So two nerves here, the femoral nerve and the obturator nerve, very important to innervate, very important innervation of the anterior hip capsule. So as you can see here, if you divide this into 4 parts, then you can see here the different types of nerve: femoral high, femoral low, obturator high, obturator low. So this is just a study differentiating all those innervations of the anterior hip capsule. Same holds true with this. So just trying to differentiate between all of these nerves as distributed over the anterior hip capsule. Now, over time, when we age, now there's a possibility that we could not see the femoral nerve. As you can see, the femoral artery and nerve are very close to each other, and you can see the iliopsoas muscle right below it. And of course, we have the fascia lata right here and fascia iliaca right there. But as we age, you can see that the distance between the artery and the nerve is becoming wider. And so if you're seeing a patient, the age maybe of 60 and above, then you have to consider that this distance kind of widens over time. And this is an important thing for you when you do an ultrasound. So right here, it's very close. This is for young patients, for femoral nerve and artery. This one is a little far. So you might want to see, you might try to look for the location of femoral nerve right here, but you don't see it. So try to see it and scan it on the more lateral side, especially for aging patients. And there you can see the femoral nerve as well. So that's a very important thing to consider if you're dealing with old patients. How about the posterior hip innervation? So the reason I would like to highlight this is because when we do lower extremity innervation, we have to also think about the joints that's being innervated by that nerve. And so these are the other two nerves that innervates the posterior part of the hip, which are your superior gluteal nerve and of course nerve from quadratus femoris, which is arising from the sciatic nerve. So these two nerves are very important to dissect. And over this this later in the lecture, I would like to show you how to approach the superior gluteal nerve as well. So this is your gluteus max, gluteus medius, this gluteus minimus, and you can see here the superior gluteal nerve located at the midway between your gluteus medius and your minimus. And then of course, same holds true here. So I'm doing a hydrodissection of the superior gluteal nerve. So the superior gluteal nerve is right here between your gluteus medius and minimus. And since the angle is very, very steep, as you can see, then you can hardly see the needle here, but you can see I'm trying to infuse dextrose as I am trying to inject the superior gluteal nerve. And that is the only way you can actually see how it approaches the area of the superior gluteal nerve. Now this approach may be difficult in the beginning, but notice here that this is the iliac fossa. So this is your maximus, this is your medius, this is your minimus, and in between your gluteus medius and minimus is where you locate your superior gluteal nerve. Okay, the summary of hip innervation then means that the anterior medial hip is coming from the anterior articular branches of troator nerve. The anterior hip capsule is coming from the sensory articular branches from the femoral nerve. The posterior hip is coming from the articular branches from the sciatic nerve. The posteromedial hip joint capsule comes from the quadratus femoris nerve. It's also innervated by the sciatic nerve. The posterolateral hip joint capsule is innervated by the superior gluteal nerve. So try to consider this innervation because these are important, especially for those doing a lot of peripheral nerve injection therapy. Then let's move on to your sciatic nerve. Now, the sciatic nerve is a big nerve because it is a combination of two nerves. These are made up of the posterior tibial nerve and, of course, your common peroneal nerve. It's formed by the ventral roots of L4 to S3, and I would say this is the largest peripheral nerve in the human body. It extends at the pelvis, at the greater sciatic foramen. It innervates the posterior compartments of the thigh and compartments of the leg. And the anterior divisions of ventral rami is found there, and of course, the posterior divisions of ventral rami are also found. So, as you can see, here is the piriformis, and of course, this is a classic representation of sciatic nerve because it exists right below your piriformis. Sometimes there are variations where the sciatic nerve could split into two parts, one in the middle of the piriformis, one below. So try to remember that. And of course, the sciatic nerve is a big nerve, so it goes all the way to your leg. Okay, now there are variations. So what you see is the classic one. So this is the piriformis muscle. This is the sciatic nerve. And then other variations is there's a split between the two parts. And then, of course, it perforates or punctures the mid portion of the piriformis muscle, or it could arise above the piriformis muscle. So it's very important that as you do your ultrasound, you know exactly what you're looking for. But if you can find it where it is from a classical point of view, then look for other areas. You might just be looking at a variation of the sciatic nerve, which is very important for this discussion. Okay, and so these are the other variations that you see here. So try to know all these variations. There could be a split of two nerves, peripheral nerve of the sciatic right here, or it could be a split of those two nerves above and at the middle. So many variations. But some of you are always trying to measure the size of nerves. You might want to find out the size of the normal nerve. So usually, if you're doing it at the level of the gluteal sulcus, it's between 0.527 plus and minus 0.028 centimeter. If it's between your gluteal sulcus and popliteal fossa, then it's between your 0.444 plus and minus 0.026 centimeter. So just remember that. Or in the absence of this specific cross-sectional area, then you can just compare the right and the left and then see if you have the same findings with the right and the left. So another interesting thing here, as I always would like to include clinical findings also, is that piriformis syndrome, okay, is only found about 6% to 8%. So if you are thinking about, oh, that could be piriformis syndrome, the pain is right at the buttocks, it's piriformis syndrome. Remember, it only represents 6 to 8%. And sciatic nerve could be impinged anywhere along its course. 43% for some studies and 13 to 40% for some studies. So it doesn't always follow. So the piriformis syndrome, some would even say piriformis syndrome is a fantasy. It doesn't exist because you don't quite see exactly what do you consider to be abnormal piriformis muscle or anything like that. And some people, instead of hydrodissecting the nerve here, they instead inject this with Botox just to release the piriformis muscle in the process of being the cause of this problem. But it's hard to tell. So 6 to 8%, we don't even know what's the criteria for diagnosis. Then, of course, you have also the deep gluteal pain syndrome. These are patients who always complain of pain on the gluteal area, which is deep into your buttocks, especially when you are seated. Now, remember, there are 4 muscles here that serves as your external rotators of the hip. You have your piriformis, superior gemellus, obturator internus, and inferior gemellus right here. So here, there could be an impingement of the sciatic nerve, not at the level of piriformis, but right at the level of the quadratus femoris muscle. So remember, when you sit down, the quadratus femoris muscle, which is below actually your inferior gemellus, is the muscle next to this level here. The quadratus femoris muscle could impinge between the gluteus max and, of course, the quadratus femoris muscle, and that's your sciatic nerve, and causing what we call the subgluteal pain syndrome or the deep gluteal syndrome. So that's a very interesting finding because the problem is really not in the proximal, but on the distal level of the sciatic nerve. And then here, so of course, in this image, you can see the inferior gemellus right there. This quadratus femoris and the sciatic nerve is right in between. Same holds true here, and this is the long axis view. So when you do a hydrodissection, this is exactly what happens. So this is your sciatic nerve right here. This is your greater trochanter. This is your ischium here. So this is your gluteus max, and then the needle goes all the way down, and then you try to hydrodissect that. It's very difficult to hydrodissect it at the lower portion because you might just hit the nerve. So what I usually do is, for as long as I can reach this area here, even at the more proximal part, then that would be enough for you to bring the 5% glucose on this area. So you actually address the impingement at that level. So this is kind of deep because this is your quadratus femoris, and we're doing the hydrodissection level. Now, another interesting findings here is of course the perineal branches. Now, sometimes when I was beginning to do your perineural, then I would try to figure out where exactly is the perineal branch coming from. Is it coming from the sciatic nerve, or is it coming from somewhere else? So as you can see in this anatomic drawing, there are 2 branches where the perineal branch may come from. So in fact, there are 2 perineal branches. One is a branch coming from the sciatic nerve. One is a branch of the posterior femoral cutaneous nerve, which is another distinct nerve that could give rise to a perineal branch. In fact, the posterior femoral cutaneous nerve, if you will follow that nerve, is the proximal branch of the inferior cluneal nerve. So before the inferior cluneal nerve, you have the perineal branch that goes into your perineum. So what am I saying here is that for you to be able to treat a pain over the perineal area, you might also inject the sciatic nerve or hard dissect the sciatic nerve, or you can hydrodissect the perineal branch of the posterior femoral cutaneous nerve. So the one that arises from your sciatic nerve, okay, it represents 67%. Okay, and it has a 33% contributions to the perineal branch of the posterior femoral cutaneous nerve. While the one that is coming from posterior femoral cutaneous nerve is also giving off branches to inferior cluneal nerves, and perineal branch represent about 50%. And so the location is usually 4 centimeter inferior to your ischial tuberosity. So this is your inferior tuberosity. Now this is your perineal branch coming from your sciatic nerve. Okay. And then of course, 4 centimeters below is where you find the perineal branch coming the posterior femoral cutaneous nerve. Now another interesting thing about the posterior femoral cutaneous nerve is they try to put a dye here, and they assess if the dye, if the fluid goes into this area while they inject under ultrasound guidance, and then of course they found out that it could actually be blocked in this area using this technique, again addressing the posterior femoral cutaneous nerve. Now let's move on to the posterior femoral cutaneous nerve. So posterior femoral cutaneous nerve is another nerve, okay, which is distinct from the sciatic nerve. As you can see the location, this is your sciatic nerve here. This is your posterior femoral cutaneous nerve. So posterior femoral cutaneous nerve is more medial, and the sciatic nerve is lateral, okay? So, and usually this is the one that is affected if there is pain over the scrotal and labiomajoral area. And sometimes this is misinterpreted for pudendal neuralgia. I just would like to know, to let you know that the pudendal neuralgia would not cause pain over the scrotum or labia majora. It should be the posterior femoral cutaneous nerve. Okay, so this is your inferior cluneal nerve, which is a branch of your posterior femoral cutaneous nerve. And of course, this is your perineal branch, which is also a proximal branch of the posterior femoral cutaneous nerve. Okay, so I just want to show you the distribution. And of course, this is your pudendal nerve here at the middle. Okay, so this comes from the lateral fibrous expansion from ischium, which is the culprit for the impingement, and it is found between your ischial tuberosity and deep gluteal fascia, and the entrapment is found the medial side of the lateral fibrous expansion at the lateral part of the ischial tuberosity in the sitting position. So this is the lateral fibrous expansion right here, and this is your posterior femoral cutaneous nerve, and this is your ischial tuberosity. So at least you can see here the location. So the pain is more lateral as compared to the pudendal neuralgia, but then it does not involve the clitoris, penis, or anus, which is the one that actually this nerve is innervating. Okay, so this is another representation of the posterior femoral cutaneous nerve, and then of course the branches right here, and the branches over this area that goes into the medial part, okay? And then of course, these are the variations of the posterior femoral cutaneous nerve and inferior cluneal nerve. So as you can see, the inferior cluneal nerve would have different variations. So several variations, but the more important fact to understand is that this all comes from the posterior femoral cutaneous nerve. Okay, so this is the perineal branch, 2 finger breadths under the ischium. That is where the perineal branch of this nerve goes. Okay, so there is a perineal pain. So the perineal pain is coming from the posterior femoral cutaneous nerve and not necessarily from the pudendal nerve, especially if it involves the scrotum in the males and labia majora in the females. Okay, now let's go to the cluneal nerve. So we mentioned already the inferior cluneal nerve as part of the posterior femoral cutaneous nerve. But this is also very small but very interesting nerves. the superior cluneal and the medial cluneal nerves, and of course, the inferior cluneal is about for femoral cutaneous. So the superior cluneal and the medial cluneal arises from different roots. So the superior cluneal arises from L1 to L3, while the medial cluneal arises from S1 to S3. So this one is for your medial cluneal. This one is from superior cluneal branch. So L1, L2, and L3. And this innervates the area at the gluteal part just below your iliac crest, while the medial cluneal nerve innervates that small part at the end part close to the posterior superior iliac spine of the ilium. So right here, okay, at the posterior superior iliac spine. So those are your superior and cluneal nerves. Now, if you will notice, the superior cluneal nerve perforates the muscle or the lumbodorsal fascia right here. And then, of course, same also with the medial cluneal nerve here, while the inferior cluneal nerves from the posterior femoral cutaneous nerve goes all the way up. And sometimes it could anastomose or reach this area at the gluteal area here. Okay, so try to remember that these are all sensory branches that could innervate this part. And then at the same time, interestingly, this also innervates or anastomose with the inferior gluteal nerve, which is the nerve that actually innervates your gluteus maximus. Okay, so there's a lot of anastomosis going on in that particular area. So if you are going to do a palpation, then you locate for the iliac crest first, and then of course the medial branch of the superior cluneal nerve is the one which is very prominent and passes through an osteofibrous tunnel. And of course the one here is this is the location of your medial cluneal nerve. So we have 3 branches of the superior cluneal nerve that goes all the way on top of the iliac crest. And you can deduce from this anatomic location that when you actually twist your back like this or bend, there's a possibility that these nerves could be stretched and could be traction. And if you do that over time, over a period of time, then there's a possibility that that nerve could also be traction and eventually injured. Now the other thing that is also very interesting here is that, sorry for that, you can also measure the distance between what you can palpate from the posterior superior spine up to the osteofibrous tunnel. This is because this is the most commonly impinged area right here. So there are 3 branches, as I mentioned. There is the medial, intermediate, and of course the more lateral. But the medial branch here is the one that passes through the osteofibrous tunnel. And the distance from the posterior superior spine up to that level is about 64.7. So it's about 6 centimeters from the midline. So if probably you put your 4 fingers, okay, then you can approximate depending on the size of your fingers, but you can probably estimate that location is where your medial cluneal nerve is located. Now, why is this important? Because the medial cluneal nerve is the one that is usually compressed. And interestingly, the compression of this nerve at the superior cluneal nerve mimics other problems on the spine, like your lumbar radiculopathy that has a leg symptoms with about 47 to 84%. That's quite high. So in other words, if you try to assess, it's possible that there could also be symptoms coming from that nerve. Or the medial cluneal nerve also represents, in some studies, 82%. So that's also high. But there is no motor involvement. So in other words, if we see any motor involvement in our low back pain, that's not cluneal nerve. It could be a radiculopathy, really. But If it is clonial nerve, there is no motor involvement as cause of impingement. Then, of course, this is the usual distribution, the medial, intermediate, and the lateral branch. You can see it there. And then this is your gluteus max, videus right here. Then, of course, this is a study made by the group of Kevin. And then you can see here and visualize the nerve as it passes on top of the iliac crest. Then you can see it also here when you do your transverse assessment. You can see the round area of the nerve when you try to locate that nerve as the osteofibrous tunnel. So you can either do it this way, transverse, then this is what you can see here. This is the rectus spinae, or you can use it going lower, then you can also see that nerve passing through the osteofibrous tunnel. So there are different techniques in trying to locate for the nerve. So this is the location, the rectus spinae. This is your spiroclonial nerve right here. This is the spiroclonial nerve right here. So we try to scan it, and this is what we see. Or this is the medial clonial nerve branch, which is also part of the superior clonial nerve. So how do we hydrodissect? So what I did is I used the iliac crest as reference, and then this is the rectus spinae muscle. That's the needle. I go right all the way to that fascia, because that fascia contains the superior clonial nerve. So look at the needle tip. So when I hydrodissect that, I actually target the medial clonial nerve of the superior clonial nerve. So that's a beautiful hydrodissected area. And of course, patient will feel relief when you do that impingement, that kind of technique in hydrodissection. Now let's go to your pudendal nerve. Again, this is a very interesting nerve because this nerve is the one that innervates the muscle right here. And then, of course, the inguinal, should I say, the perineal area is also innervated by this nerve. So there is a mixed somatic and autonomic nerve from S to S4. It innervates the pelvic floor muscles, the external urethral, sphincters, and pelvic organs. So the most common area of entrapment happens here at the Alcax canal. I would like to identify this area later on in this lecture. And then you can see other areas of impingement of this nerve, but the most common is, of course, the Alcax canal. So that's your ischium right here. So the way to scan it is to go to the ischium, and then you go oblique, and then what you see is a flattened ischium, which looks like this. And usually the pudendal nerve is accompanied by a pudendal artery and vein. And then when you try to do Doppler, then you can see that nerve at that end tip of this ischium. So the tip of this ischium right here is where the pudendal nerve is usually located. So that's how you can locate for the pudendal nerve at the end of this ischium. When you see it flattened already, then that's where you need to see. So this is the location of the pudendal nerve. That's pudendal nerve, and the Alcax canal is right at the medial portion of that inner part of the gluteus, where the entrapment happens, impinging your pudendal nerve. So there are different variations. As you can see, there's a ligament right here in between your iliac spine and, of course, your sacrum over here, and that is really your sacrospinous ligament. And somehow that is where you see the different variations of the pudendal nerve, okay? And then in relation to the sacrospinous ligament. And in a way, the sacrospinous ligament is also involved in the impingement process. So in the pudendal neuralgia, okay, so this is, let's say, your sciatic nerve, that's your pudendal artery, that's your gluteus max. Okay, the pudendal nerve is usually medial to that. And this is your ischial spine. See, ischial spine, sciatic nerve, pudendal nerve right here. So that's how you can locate this structure. Then what I did is to do a hydrodissection, so you can see the ischium flattened. Okay, so I put the needle all the way to the tip of that ischial spine, ischium, I should say, and there I hydrisect that area because that is where your pudendal nerve is actually located. Now let's go to your lateral femoral cutaneous nerve. So this is a pure sensory nerve coming from L2 and L3 nerve root, innervating the skin of the anterolateral and lateral thigh. So this area here, the patient complains of sensory deficit, numbness on this area, then you can be sure it's your lateral femoral cutaneous nerve. And as you can see here, this nerve is lateral to the femoral nerve. So if this is your femoral nerve, lateral to that is your lateral femoral cutaneous nerve, and it's underneath your inguinal ligament. And of course, the normal cross-sectional area, about 1 to 2 millimeters. This is really not present in everyone, so sometimes it could vary. But anything that is more than 5 millimeters is already considered abnormal. So if you measure it and it's more than 5 millimeters, then that is a very swollen lateral femoral cutaneous nerve. So to locate, you look for the sartorius and your tensor fascia lata, and then over the top, that is the location of your lateral femoral cutaneous nerve. So here you can see this is the sartorius, the tensor fascia lata. Then I try to see there is a very thin nerve right here, and so I go below the sartorius, I dissect that nerve, and then I go up again, and then I dissect the superior part of the lateral femoral cutaneous nerve. So that's how you can do it. It's quite easy because it's very direct. You can already see it very near the anterior superior spine. You go below, and that is where you can see that. Now, there are a lot of variations, as you can see here. These are different variations of lateral femoral cutaneous nerve. I just would like to let you know that all of these variations could be present in any of our patients, so just be conscious about that. So this is a fat filled flat tunnel between your sartorius and TFL. It could cross into the proximal thigh by crossing the ascis, or it could cross more posterior to the lateral femoral cutaneous branch, crossing the iliac crest. So those are just variations of these nerves. So again, these are just different branches and patterns of the posterior lateral femoral cutaneous nerve. So when there is an entrapment, you call this the neuralgia paresthetica, and the pain is more when standing and walking, or repetitive hip extension resolved when sitting or lying down. At the anterolateral thigh pain, numbness, or dysesthesia, it's present about 4.3 over the 100,000, or 6 to 6.7%. So it's not very common. Could be present when the patient is pregnant, obese, or wearing tight clothing, or there is a limb length discrepancy. Now, study was made measuring the distance of the lateral femoral cutaneous nerve in relation to the anterior superior spine. And what they're saying is that the farther the nerve is from the anterior superior spine, the less the chances of this nerve to be impinged. But the closer the distance of this nerve to the anterior superior spine, the higher the possibility of impinging the lateral femoral cutaneous nerve. So that's just another information that you can understand when you actually scan and see the lateral femoral cutaneous nerve in relation to the anterior superior iliac spine. So again, these are the different distances that you can consider when you try to assess the lateral femoral cutaneous nerve. Of course, this is an example of a nerve that is, of course, causing a lot of pain in patients. So they remove it. There's a neuroma of the nerve, and that's what they see. Of course, EMG can also be used to assess the nerve with resulting higher snap amplitudes. Now let's go to your obturator nerve. The obturator nerve is coming from the anterior division of the ventral rami of L2, L3, L4, and this is considered, L3 is the largest of all those branches. It divides into anterior and posterior division, and the anterior is the sensory to the hip joint and mid-thigh motor innervation of the superficial adductor muscles. So this is your anterior. The posterior is sensory to the posterior knee, joints and motor to the deep adductor muscles. So very interesting that the obturator nerve could reach up to the knee. Now, there are times that I've learned before during the past PIT conferences that you also need to inject the obturator nerve. And I was curious why. It is because of this, because the posterior branch goes all the way to the knee, at the posterior knee area, which is where it is. And in a way, it could also contribute to the pain. And any problem with the obturator nerve can also cause pain on the knee joint. So it's located beneath the pectineus muscle, which is right here. And then, of course, 1.7 centimeter vertically and 2.7 horizontally from the pubic tubercle. And it may cause obturator neuropathy because of the pressure injury to the obturator nerve at the obturator foramen. It could be a pain or loss of sensation over the upper medial thigh with or without hip adduction weakness. So that's the location. So that's the location also of the pectineus muscle. So right here, you can try to ultrasound it this way. You can see the pectineus, the big pectineus muscle. It's the adductor longus brevis, then the external oblique, of course, below. So that's the location. And of course, it's your pectineus, this is your obturator nerve. This is the obturator externus, pectineus. So those are the locations of this nerve in relation to the muscle. So usually the anterior obturator nerve is located between the obturator longus and brevis, and then the posterior obturator nerve is located between the obturator brevis and magnus. So that is how this nerve is distributed in the medial thigh. So that's just another distribution of the obturator nerve. So you can do a block. Okay, you can block both the posterior and anterior branch. And this is done between the pectineus and the obturator externus. Okay, some anesthesiologists are doing this in order to just block one nerve with one entry. Same holds true with this one. And then, of course, you can see here that this is your adductor longus, this is your brevis, and then, of course, these are the nerves of vastus medialis, the saphenous nerve right here, femoral triangle. And then, of course, they're saying that when you inject this part, it could spread up to the saphenous nerve. So that is a subpectineal obturator nerve block. And then, of course, we go to the saphenous nerve and the nerve, the vastus medialis. And so we're saying that there are no terminal branches that innervates the knee, because what we know is that it is the posterior obturator nerve that goes into the posterior knee. So the variation of anterior obturator nerve, there's a cutaneous branch of the anterior obturator nerve that innervates the medial thigh, and there could be an anomalous nerve that could, which is a direct branch of the anterior obturator nerve, but not from the subsartorial plexus. It could terminate in radiating fibers at the posterior half of the medial ankle and foot. So it could reach up to the foot. These areas are normally innervated by the saphenous nerve. So what we're saying here is it could not just be a saphenous nerve, it could also be an obturator nerve because it goes all the way up to the foot. Now, the question of not everybody agrees that there is such a geniculate nerves. So the question I'm raising is, are they real? Are they really real? So what they found out in the literature is that there could be these three sources: the femoral nerve, the obturator nerve, and the sciatic nerve. So the femoral nerve becomes the superomedial branch of the genicular nerve, and it also contributes to superolateral branch of the geniculate nerve. And then, of course, the saphenous nerve here becomes the inferomedial branch of the genicular nerve, and then, of course, can also contribute to the superomedial. While the obturator nerve, okay, the anterior branch give rise to the posterior medial and the posterior branch. And then the sciatic nerve, superolateral, okay, and the inferior-medial. So what we're seeing here is the sciatic nerve goes into the lateral part more, And the femoral nerve goes into the medial part more. And then, of course, the inferior branch could be a contribution coming from the femoral nerve, and of course, the sciatic nerve as well. So all of them give rise to the genicular nerve. So where are they located? Usually, when you do an ultrasound, of course, this is an anatomic landmark, and you can see here the different nerves that goes all the way to the knee. So if the question of is it real? So this is the lateral branch. This is your medial branch. So you can see tiny fibers there. It goes in that area. But sometimes it can be challenging to see that in the ultrasound because it's just very small. So sometimes we can use references or landmarks just to know where exactly it is. So here is the final distribution. So superior medial gluteal geniculate nerve is coming from the nerve de vasus medialis, which is actually coming from the femoral nerve. Superior lateral geniculate nerve is from the sciatic nerve. Inferior medial is the posterior articular nerve from the sciatic nerve. Inferior lateral is the common fibular nerve, which is the common peroneal nerve. And inferior posterior base sciatic nerve is also the saphenous nerve. Now let's go now to your saphenous nerve. So far so good. I hope you don't get tired. This is a long lecture. So saphenous nerve is the longest sensory branch of the posterior division of the femoral nerve. It travels along the lateral aspect of the superficial femoral artery in the proximal thigh within the adductor canal. Okay, so if you look at the nerve here goes all the way this way. And usually what we're looking at actually is that branch prior to reaching the knee. So that is your saphenous nerve. So in the saphenous nerve, okay, this is the branch. Okay, and then of course, this is your vasus medialis, right at the medial part of the knee. And this is where it is. It is accompanied usually by neurovascular bundle. So if this is your sartorius, this is your femoral vessels, then this is your saphenous nerve right here. Same holds true with this one. So the first thing to find out, actually, you can do two things. You can identify the sartorius, and then posterior to that is your gracilis. Sometimes if you have a hard time trying to locate for that, all you have to do is first look for the femoral vessels, because the femoral vessels will tell you that on top of that muscle is your sartorius muscle, and that right anterior, or should I say medial to that, is your saphenous nerve. Okay, and then of course there is a nerve to the vasus medialis with a very small motor branch just close to the nerve. So again, this is the one that's affected, and well, this is a very interesting finding, because what we're saying is this canal here opens during knee extension, that is the adductor canal, and then it closes during knee flexion. So what we're just saying is, if you are, that's why they call it economic class syndrome, because if you are actually taking the economic class, your leg could hardly move, and then you're a candidate for deep vein thrombosis, which is the vascular structures just close to that. So this is your sartorius, this is your vasus medialis, this is your saphenous nerve. So I'm going to do a high dissection of this nerve, which is right here. Okay, so this is the neurovascular vessels here. So I try to hydrodissect the upper portion first, and then I go deep to this, and then just hydrodissect the nerve right below, so that I can completely hydrodissect that. So I'm just trying to be careful with the neurovascular structures that is below this. Okay, that's why here you can see that there are Dopplers that I would like to see how these vessels are shown. Okay, so here this is the saphenous nerve in relation to the Hunter's canal. So that's your saphenous nerve. Then that is your saphenous nerve, the sartorius saphenous nerve right here. It enters into this fascia here, okay, that makes up your Hunter's canal. So they call it the vasoadductor membrane. Okay, so we'll move farther. So the saphenous nerve gives off branches into the different parts of the femur and of course the knee. So as you can see, there are the distribution scattered all over the place. Okay, in relation to your vastus medialis, then you can see here the femoral bone inside. And so that is where the direction of the saphenous nerve is going. So summary of nerve supply of the knee. Obturator nerve, no terminal branches of this nerve in the terminal capsule of knee. Although we've seen that 11% is found innervating the knee, usually at the posterior part of the knee. Terminal end branch cannot be determined, although blocks contribute to relief. So this is a very important information. And of course, sciatic nerve, superolateral geniculate nerve for the posterolateral knee pain, most strongly described as branch of the nerve vastus lateralis or common femoral nerve. The second nerve is posterior articular branch, the branch of the tibial portion of sciatic nerve before bifurcation. It innervates the inferior medial aspect of the knee capsule. So that is just the summary of the supply of the knee. And of course, this is your adductor canal nerves. We knew that already. And then, of course, these are just different approaches where actually you can inject the femoral nerve, and then you can also inject all the way to the sciatic nerve. You see that? One approach, anterior to posterior. I don't know if you will be interested in doing that. Okay. So again, that's the other summary of the knee geniculate nerve. Then of course, we'll move to the next nerve, which is a sural nerve. So sural nerve is a very interesting nerve because it is the union of the medial sural cutaneous nerve from the tibial nerve, and of course, the lateral branch of the common perineural nerve, which forms the lateral branch. So the lateral cutaneous branch of the common peroneal nerve and the medial cutaneous branch of the posterior tibial nerve give off branches to become the sural nerve. But of course, as you can see here, there's a lot of variations, so many variations of those nerves. So how do you locate for the nerve? It is located between the two heads of the gastrocnemius muscle. So if you are looking at the more proximal portion, all you have to do is to look first for the lateral and the medial gastrocnemius head, and the sural nerve is right in between. And of course, underneath is the soleus right here. So that is the track of the sural nerve. And as you go down, you can see here that the nerve is very close to the Achilles tendon. And then of course, anteriorly, you can also see, which is not in this picture, is the peroneal muscles. And it goes all the way here, here, and then on the lateral part of the foot. So you can also check it on this area just at the posterior of the peroneal muscle. And the clue to this is to look for the lesser saphenous vein. And when you look at the lesser saphenous vein, then just beside the lesser saphenous vein is the sural nerve. And that is where you can hydrodissect that area at the portion. Of course, there's a lot of other different variations. So just would like you to see all those different variations. Then of course, again, the sural nerve right here, lesser saphenous vein, sural nerve. This is the adductor digitorum longus. This is the peroneus brevis and longus. This is the sural nerve right here. And then of course, we did a hydrodissection. So as you can see, this is the sural nerve, lesser saphenous vein, Achilles tendon, longus and brevis muscle. Okay, it should be here. But anyway, I tried to hydrodissect that nerve. Okay, and then so it separates now. And so that's how you can approach that sural nerve at the leg, or at, should I say, at the ankle. Then we'll go to your common peroneal nerve. So common peroneal nerve arises from sciatic nerve, innervates the short head, the biceps femoris, and it gives two branches, the sural communicating branch by the tibial and the lateral cutaneous branch at the calf. And of course, it passes through the fibro-osseous tunnel at the superficial head of the peroneus longus, then divides into superficial and deep branch. The superficial splits into the medial and lateral terminal sensory branch. And of course, there is also several areas of entrapment of this nerve. So usually it entraps right where it moves around the fibular head. And then of course, the distal part right here, which we will show you a little later. So as you can see, this is the direction of the superficial, the common peroneal nerve, branches into deep peroneal and superficial peroneal as it moves. So here is how we do the hydrodissection. So this is at the level of the knee. So we try to hydrodissect the common peroneal nerve right here. Okay. So the common peroneal nerve is hydrodissected. That's just below the semitendinosus muscle. And then of course, should I say the below your biceps femoris muscle, I should say. So that is your common peroneal nerve here, and which is being hydrodissected. Okay. And then of course, there is a superficial peroneal nerve here as it actually moves into the fascia level. Now, if you scan the superficial peroneal nerve at this level, you will notice that proximally they're underneath the fascia. Okay. Then, as you go below, it moves above the fascia onto the top. So this is, let's say, the higher level. This is the higher level. Then it moves and exits at this fascia here. So we'll show you how it looks like as this moves. So this is the superficial peroneal nerve. The superficial peroneal is underneath the fascia, but as it moves, look at this. It moves up the fascia. So in other words, this is an area of entrapment here as it exits. So when this muscle goes into spasm, then of course, this nerve could be entrapped on this area. Okay, so it emerges from the fascia, and that is at the distal third of the leg. So this is another representation. So what I did is to do a hydrodissection of this nerve. So that's the nerve right here. So this is the fascia. So I tried to hydrodissect the uppermost portion first. So there is a separation of that layer, the fascia layer. And so you can see the nerve right here. That's a honeycomb pattern. So it's a beautiful hydrodissection. You can see the nerve that's being decompressed on this area. So this area is the area of entrapment of the superficial peroneal nerve. Now, how about the deep peroneal nerve? So there are two sides of the deep peroneal nerve. And as you can see, there is an anterior interosseous membrane deep to the extensor digitorum longus. And then, of course, the nerve is located here. This is your nerve. This is your extensor digitorum longus, extensor hallucis longus right here. So when you put your probe here, this is how it looks. When you probe your put your probe here, this is how it looks like. So at this level, you can see the deep peroneal nerve very close to the dorsalis pedis artery. Okay, so there is also an impingement at the foot, okay, right between your cuneiform 1 and M2. This is the dorsal band of the Lisfranc ligament. And this is also another branch here, and then another branch here. So this is already at the foot level. And then you can also check the details of the other branches here. Of course, it's the deep peroneal nerve. Then this is the medial branch, So that's the location of the deep peroneal nerve. And then the entrapment can happen, of course, anywhere, right here, or it could happen here, which we call the anterior tarsal tunnel syndrome. There's a fibrous tunnel composed of the retinaculum, the extensor tendons, and then this is the partial anterior tarsal tunnel syndrome. One branch of the deep peroneal nerve is compressed right here. This is between your cuneiform 1, cuneiform 2, M1, cuneiform 2, and M2. This one, this is the Lisfranc joint. Okay. So again, this is the deep peroneal nerve at the foot. Here, I did a heavy dissection of the deep peroneal nerve at the level of the dorsalis pedis. So that's the deep peroneal nerve. So I kind of hydrodissect that area. Okay, so you can see here the deep peroneal nerve during hydrodissection process. And then I go also all the way up to try to hydrodissect that same nerve right here. So you can do it under ultrasound guidance that way. So the lateral branch of the deep peroneal nerve can be the cause for the anterolateral foot pain. And this could be misconstrued as a lateral ankle sprain because of the compression of the lateral branch of the deep peroneal nerve, as I've said, at the anterior tarsal tunnel. So when the foot is inverted and plantar flex, that nerve could be stretched and could be compressed over here. So this is what they call the anterior tarsal tunnel syndrome. Central lucis, external digitorum. This is the deep peroneal nerve right here. This is another deep peroneal nerve here at the level of the ankle. So let's go now to the deep or the posterior tibial nerve. So again, this is the branch of the distal sciatic nerve from L4 to S3, and it enters the leg between the two heads of the gastrocnemius, runs deep into the soleus at the deep posterior compartment of the leg. And it lies between the tibialis posterior and flexor digitorum longus in the upper leg, and also between the flexor digitorum longus and flexor hallucis longus in the lower leg. And 79% will have cancalial nerves, which could go to the abductor hallucis and sensory to the medial heel of the pad and innervates the gastric soleus and the popliteus muscle. So this is your posterior tibial nerve. So these are different types, just for you to see the different types of the posterior tibial nerve. So the posterior tibial nerve passes underneath the tibial tarsal tunnel, the tarsal tunnel right here at the medial foot. And then, of course, it has all these branches. It has a medial plantar branch. That's the first branch that is entrapped at the knot of Henry. Of course, prior to that, there is also a calcaneal branch that also arises from the tibial nerve. And then, of course, the lateral plantar nerve, which actually becomes your inferior calcaneal nerve or the Baxter's nerve, that also causes pain at the heel and sometimes misconstrued to be heel spur. And then we do an X-ray and it doesn't show any heel spur. So usually that is the nerve that is compressed. That is the Baxter's nerve. And of course, you can see here the distribution of all these nerves, 1, 2, 3. These are the medial, lateral, the inferior calcaneal branch, the nerve. Then of course, right here, I did a hydrodissection of the posterior tibial nerve at the tarsal tunnel. So you can see here the tibial is posterior, and of course the flexor digitorum longus, and then I kind of hydrodissect the posterior tibial nerve right here, which is a honeycomb pattern. And then as I try to hydrodissect it, I kind of separate this and decompress this area so that there will be decompression in this level of the foot. So the posterior tibial nerve, as mentioned earlier, has also a medial calcaneal branch, and this is a sensory branch to the heel pad in about 64% of patients. So this branch usually goes and separates from the tibial nerve prior to entering the tarsal tunnel. So this medial calcaneal branch will go, calcaneal nerve will go to the heel part, and as mentioned in the study, 64% of the sensation on the heel is coming from the medial calcaneal branch. And of course, the inferior calcaneal nerve is coming from the lateral plantar nerve in 81% of cases. So we already mentioned that earlier. So in other words, this feet at the dorsal part is innervated by, of course, the superficial peroneal nerve, the sural nerve, and of course the deep peroneal nerve. Same holds true with this one. This is the medial plantar nerve, lateral plantar nerve, medial calcaneal branch, and of course the sural nerve. This one is your saphenous nerve. Can you imagine the saphenous nerve goes all the way to the flutes? And then, of course, that's the tarsal tunnel. We have seen that already. That is the tibialis posterior, flexure digitorum. And then, of course, the muscle here, the vein, and then, of course, the nerve. So this is the long axis view of the tibial nerve. It could have different branches. And of course, what we call as the jogger's heel is actually the impingement of the medial calcaneal branch of the tibial nerve, which I mentioned earlier to be exiting before it enters the tarsal tunnel area. So again, these are the different variations. And of course, the lateral plantar nerve arises from the inferior calcaneal nerve arises from the lateral plantar nerve, which becomes now your Baxter's nerve. And this innervates the flexure digitorum brevis. So again, the safe zone for injection, if you divide this area into different parts, the safest area is between the third and the fourth section, because this is where there is not much neurovascular bundle. So this is the area where you need to inject if you are going to do a hydrodissection of the posterior tibial nerve. And then, of course, these are the different representations in the muscle. Again, the medial calcaneal nerve. This is the medial plantar, lateral plantar, of course, the inferior calcaneal. Then, of course, the different muscles that you see on the foot. And of course, the Baxter's entrapment site could happen at the proximal, at the lower calcaneal tube, or at the medial calcaneal tuberosity at the plantar fasciopathy. So these are just giving to you the idea that this could be entrapped anywhere in this area. Okay, same holds true with the other nerve. And then, of course, that's your nerve. That is your quadratus plantae. This is abductor hallucis. That's your Baxter's nerve right there. So again, this is another location. This is the distal approach. Okay, so this is the Baxter's nerve, lateral plantar, medial plantar. So the needle approach this way, as you can see in this representation. Again, these are the plantar nerves. Okay, you divide into different sections. The medial plantar, the lateral plantar, the inferior calcaneal branch. Okay, same holds true with this one. And the other interesting thing is the medial plantar nerve is usually located between your flexure digitorum longus and flexure hallucis longus tendon. And then the medial plantar nerve is located right here. So these are the different distributions of the digital nerves. And of course, this is also the third web space where you find those two nerves at the distal part, anastomosing. That is the reason for the Morton's neuroma. So this is a representation of the hydrodissection of the medial plantar nerve. So these are the two tendons of the flexure digitorum longus and flexure hallucis longus as they try to form at the knot of Henry. And then, of course, your medial plantar nerve is right here. So I approach it from here, and then I try to hydrodissect the medial plantar nerve on this area. So you can just inject that nerve that may give you a medial foot pain that's causing a lot of pain, especially when you put weight. So that's a medial plantar nerve. This is your lateral plantar nerve over here. Okay, so again, the location of the interdigital nerve is usually below. This is the intermetatarsal ligament above, and then there's the bursa right here. So this is the between the third and the fourth So this is the third web space for the Morton's neuroma. And of course, this is where you can find, you can do a Mulder's maneuver. This is the most common approach for looking at the nerve. And this is what you can see, a cobra sign. The nerve goes all the way up that way, and then you apply pressure below so that you can see the nerve emerging from below going up. Okay. Now, it is also possible that there could be other nerves, especially the medial proper plantar digital nerve, which we call the Joplin neuroma, at the bunion site. Okay, that's the bunion site. You have pain there. It could also just pain because of the nerve, or it could be a bunion. So you have to look at this nerve here. That is your medial hallopal digital nerve. I would like to thank you for your kind attention. This is such a long lecture, and I know you're tired of listening to this lecture, but I hope you learned something out of this lecture. Thank you, and God bless you all.